Today's discussion is diabetes mellitus in pregnancy. And I've always emphasized the fact that whenever we look at a medical or surgical condition complicating pregnancy, we need to look first at the basics of that condition, devoid of pregnancy. And then after we look at it in general, then we can narrow down on pregnancy itself. So, let's start with our course outline. So we'll look at the definition of diabetes mellitus, then we'll look at the basic pathophysiology, which makes reference to a diagram that I've drawn, very simple and basic diagram. Then we'll look at classification, both in general and in pregnancy. Then we'll narrow down on gestational diabetes mellitus, which says something about it, and what exactly is the glucose tolerance, or indeed intolerance, and what is the oral glucose tolerance test. Then we'll look at effects of pregnancy on diabetes mellitus, just like we'll look at effects of diabetes mellitus on pregnancy. And under that one, we'll look at fetal and maternal effects. Basically, you shall see that these are general complications of diabetes mellitus, because that's what the condition is doing to pregnancy, both to the mother and to the baby. Then we will narrow down on management of diabetes mellitus in pregnancy, and we always start with preconception. Very important before we get to antepartum, intrapartum, and postpartum management. But in both cases, except for preconception, because the baby is not yet developing, we'll look at fetal and maternal aspects. So that's the simple outline that we'll go by. Again, suffice to mention that they are notes with respect to this lecture, and so I'll just highlight the important aspects that will need to be discussed for us to appreciate this topic a bit more. Definition, very basic. What is diabetes mellitus? Diabetes mellitus is defined in two ways. It's an endocrine or a metabolic condition in which there is, again, two things: either absolute or relative lack of endogenous insulin. So it could be metabolic, it could be endocrine, whichever direction you are looking at it, in which there is relative lack or absolute lack of endogenous insulin. Now, how does diabetes mellitus differ with another condition which starts with diabetes, which is basically diabetes insipidus? If you remember very well, the posterior pituitary gland releases a hormone known as antidiuretic hormone, also called vasopressin. And we know that vasopressin is important in water reabsorption at the level of the kidneys. And it's very interesting, ADH behavior, because it behaves by second messenger pathways. And also, what is also funny about antidiuretic hormone in the kidney is that the channel that will be used to allow water leave the nephron, let me even point to what looks like a kidney. This is the outer filtrate. Water is moving up in the nephron from the Bowman's capsule here, from the glomerulus, the Bowman's capsule. It enters the proximal convoluted tubule, down to the descending limb of Henle, ascending limb of Henle. It seems to have a thin and thick segment. Remember, back to physiology. Then it enters into the distal convoluted tubule and then down into the collecting duct. Now, somewhere in the collecting duct, there are what are called principal cells. So, in the principal cells, what will happen is that when ADH, due to changes in what is known as the plasma osmolality, which is one of the key drivers to ADH secretion. There's another driver, but we don't want to go into physiology too much. What will happen is that there will be some second messenger pathways that will emanate, which will lead to production of water channels. Do you remember the name of those water channels? They're called the aquaporins. There's aquaporin 2 and 3. Aquaporin 1 is found somewhere here in the ascending limb of Henry, where we have the sodium potassium fucmeride co-transporter, a transporter which carries 3, which is very crucial in the countercurrent mechanism in terms of the multiplier mechanism of the kidney. Now, what am I trying to say? What I'm trying to say is that it will produce the aquaporin, and the aquaporin will go and sit and draw the water. So they are not like they are channels which are already there. They are only produced. Now, if you have problems with producing the aquaporins, water will not be absorbed. You will be passing a lot of urine, which will be tasteless. A long time ago, before I just testing urine, can you test these samples of urine? This one is tasteless. Diabetes insipidus. This one is very sweet. This is diabetes mellitus. That was academic in discipline. But there will be no sugar in that. Then the other thing is that probably the problem is not at the level of the kidneys, but it's coming from the brain up there in the pituitary gland, and that's where you have this other form of diabetes insipidus. So I've taken some time to just say diabetes insipidus is no way connected to diabetes mellitus. Diabetes mellitus has everything to do with insulin. Either you don't have insulin completely, or you have insulin, but the insulin is not working. Either it has been blocked, or things like that, or it has just become insensitive, or there is autoimmune destruction of the isolates, as we shall see, and so on and so forth. Now, let's look at the basic pathophysiology. Okay. So, when you look at the most basic physiology of diabetes mellitus, very simple, something you can even explain to your patient to understand. Because don't forget that diabetes mellitus, hypertension, asthma, sickle cell, epilepsy, these could be long-term conditions that the client just needs to understand. It's unfair to have a client who is diabetic from childhood but doesn't know the condition. Doesn't even know why that insulin is being injected. So make a simple diagram like this for them to understand. Now, what happens is that when you eat food, like some of you like taking pizza, chips, chicken, you eat, let's say, carbohydrates. That food will enter the mouth to start going down from the salivary amylase all the way down. It will be broken down. It will find some gastric issues there. Then it will go and find the pancreas, discharging in the second part of the duodenum. What is all this which is happening? There is the digestion. So the carbohydrate is being broken down into smaller particles. Mind you, carbohydrate is a polysaccharide. It will break down to disaccharides, then into monosaccharides. Now, one of the monosaccharides that will be produced is glucose. Remember, before the glucose, you could have had maltose, you could have sucrose, all those things, but later it will just end up with either galactose, glucose, or fructose. Those are like the smallest kinds of monosaccharide. Now, the issue with the diabetes is glucose. What happens to the glucose as it reaches here? It will be absorbed by the intestines. Now, when the glucose is absorbed, this final shaped thing is an intestine, it's a vessel. So when glucose enters the blood vessel, what happens? It will be surrounded by cells. These are cells. Just ordinary cells that are metabolizing. And this glucose should not remain, neither should it remain in the intestine. It should not remain in the blood. But where is it needed? It's needed inside the cell. Now, how will this glucose enter the cell? It will enter the cell through a gate. And that gate essentially is insulin. So think of insulin as a gate all the time, which allows entry of glucose. So strictly speaking, we can now start looking at GLUT1, GLUT2 receptors and all that, but that will be a discussion for another day. I'm just assuming I'm explaining to a lay person. Now, if the glucose enters here, what will it do? It will be involved in metabolic pathways. One of them is glycolysis. Remember glycolysis? Glucose 6-phosphate, fructose 6-phosphate. It breaks into, now we have the anodes, then it goes glucose 6. You have that, and then later on will be production of energy. After it passes through the Krebs cycle or the tricyclic acid pathway, and then to enter into the electron chain pathway, and then what you have a lot of ATP, a lot of energy. Carbon dioxide will be released at that point. And we say that somebody is now having energy to do a call or a word round. Or coming from glucose, which is coming from the enzyme, like some of us, we eat enzyme QID. That's a dose they prescribed for me, my doctor, who happened to be a physician. So, you find that this is what happens. Now, let's look at a situation where you don't have the gate. You don't have insulin. So a child is born without insulin. What will happen? It means they will be eating porridge, milk, breast milk, whatever. And a lot of glucose will be produced. A lot of glucose will enter the blood vessels here, the hepatic portal system. But this glucose will not enter the cells. So what are the ramifications of that situation? Number one, the sugar levels will change behavior. The fasting blood sugar is supposed to be between 3.5 and maybe 7.8 millimoles per liter. I'm just using again several authorities have got several numbers. The American Diabetic Association has its own numbers. WHO has got its own numbers. My teachers from Britain have their own numbers. But stick to one authority, because if you have a lot of mixture of authorities, nice guidelines say this one is saying this, there will be so much confusion. So you even quote to say my figures are as a result of this authority, 2025. Don't give very old one, 1920. At least something latest. Now, this is the fasting blood sugar before you eat. It should be somewhere around here. Random blood sugar should not cross 11.1 millimoles per liter. It can be anything, because when you eat, the sugar goes up, but it should not reach up to 30 millimoles. That is too high. It means you are losing your compensatory mechanisms. So, this is basically like our normal values, generally. Now, what will happen? Because we've got so much sugar, which is not being taken up by the cells, what will happen? The sugar values will rise when you do a random blood sugar or a fasting blood sugar. Now, let's go to the kidney. Where does this blood eventually go? It reaches the kidneys by ultrafiltration and the Bowman's capsule. Of course, there's a lot of story on the kidney here. You have the Messenger cells, the glomerular apparatus, and all many other things you can talk about just around the kidneys here. And the macula densa. The kidney is one of my favorite organs because it's very versatile in what it does. And it's upset very easily. But again, if you can correct what you have caused, it can easily pick up again. So much you can say about the kidney. Now, let's look at filtration. A lot of glucose is deposited in the nephron as an ultrafiltrate. Do you know what the body will do? Glucose is a small molecule, so it will pass through the basement membrane, at the level of the glomerulus there, that junction with the Bowman's capsule. Now, what will happen is that this glucose, which is a small molecule, all of it is supposed to be reabsorbed. All of it. In fact, it goes mostly through what is called obligatory pathway. If we went into all the transport mechanisms within the kidneys, nephron. Now, This glucose, all of it is supposed to be absorbed. And now the body can take up to 10 millimoles of glucose back into the blood vessels. Because you see these red ones, these are the peritubular capillaries. So it's like you have got stationed capillaries which are able to pull back what is important, which was almost being lost. So that in this nephron you only remain with irrelevant things which will be lost as urine when it passes through the calyceal parts and the pelvis of the kidneys. And then it goes as a ureter, and then blood, and then urine is produced. So now, if your sugar is up to 40 millimoles per liter in blood, do you know what will happen? The body would have taken 10 millimoles, because that's its maximum, and it's called the renal reabsorption threshold for glucose. What will happen to the 40 minus 10? 20 millimoles. It will remain in the outer filter. And what will happen? Where glucose goes, water follows. No wonder I was saying obligatory, because water just follows. Just by the time we should be making a corner at the Chisari junction, even if you make a corner. Yeah, like you're just moving. It makes a corner and you're following a corner. That's what happens in the relationship between glucose and water. So, you find that there will be a lot of polyuria, because one will be passing a lot of urine because that water is following glucose. But at the same time, there will be sensors that will go up to the hypothalamus, one of the nuclei in the hypothalamus. You don't want to ask you all the nuclei in the hypothalamus. There's nucleus ambiguous, nucleus solitarius, nucleus everything, which will now detect to say the water is being lost, and it will increase the thirst center, and somebody will be passing a lot of urine while at the same time will be very thirsty. In fact, one way in which you can capture a diabetic is somebody who you know moving with a 5-liter container of water like this. Yeah, I'm seeing them with a glass. Water, they drink, they put some water. Now you can be wondering, this person is drinking water like this. What's the problem? That could be one of the first signs, or waking up several times at night to pass large amounts of urine. That would be the sign. Now, away from that, let's look at what is happening in the individual cells. The cells, if they are not receiving glucose, what will they do? They will find the plan B to make sugar within itself. And what will that plan be? It will be to digest the fat, because there's fat within the cell. And this is called the beta oxidation of fat pathway. Remember it? And what it will do is that in the process, it will make some glucose, which is good for the cell. The cell will use it. But it has a bad byproduct known as the acids. And which are these acids? We have alpha-ketoglutarate acid and the acetoacetal or acetoacetic acid. These two ketone bodies or acids, they will be produced and they will be excreted in urine. No wonder you find that in the dipstick, you find the glucose is 4+, ketones is 3+, because you are producing a lot of acids. And these acids are not good. Why? Because they will lead to diabetic ketoacidosis. How does that come about? Again, it takes us to the kidney. We just need a lecture to just discuss the kidney, both anatomy and physiology. What happens to the cortex, to the medulla? I've already talked about the countercurrent multiplier, but there's also a countercurrent exchanger. Two different pathways. One is to do with the vasa recta, the other one has to do a lot with the loop of Henle. Now, what is it about the kidney? Don't forget that when you increase these acids, these organic acids like the ketone bodies, the body will try to compensate by pushing out carbon dioxide. So it's like it's a metabolic problem, but its compensation is respiratory. Again, that will be understood when you look at acid-base balance and the role of the buffer systems in the body. So, when a patient will start having Kussmaul's breathing, deep breathing. It's like gasping, but gasping fast. That's how I can describe Kussmaul. Again, patient will become semi-conscious. And when you check the sugar, it will be writing as HI, meaning too high for the machine to read. Unless maybe if you use a laboratory machine. And at the same time, you find that there will be a lot of glucose and ketones in your urine, like we have said. And that's how you make a diagnosis of diabetic ketoacidosis. But I mean, these are external parameters. You might as well need to check for an iron gap. You need to check for, because when you look at metabolic acidosis, you have to know whether it's a normal anion gap or there is changes in, or the anion gap has become wide. And then also you need to check for bicarbonate, you need to check for the pH and the other parameters, partial pressure, carbon dioxide, I mean things that you can use on the ABG machine to have the numbers. Not just looking at the patient. Madam, I think you are no longer in decay. Just by looking. Clinical diagnosis, you need to have numbers, and an ABG machine becomes very important. Okay, now, away from DKA, there will be weight loss. Why is there weight loss? Obviously, you are digesting the fat, and most of the diabetes will lose weight. They will be losing weight, almost becoming cachexic, just bones. I've seen that before, and people will continue doing HIV testing. It should be negative. Others are even upset, Dr. Mulenga. Why is it non-reactive? Why? As if you are wishing the patient bad luck. Think widely. What else can lead to somebody losing weight so rapidly other than? So just a good history, you'll be able to pick some of those classic symptoms. The other issue, so they are eating a lot. Why are they eating a lot? It's because of the same sensors which are within the cell picking up to the hypothalamus. So all in all the symptoms and signs of diabetes mellitus can be explained by a simple pathophysiology diagram. Now, we know that the insulin comes from the isolates of Langerhans, which is the beta cell somewhere in the pancreas here. Because the pancreas is fine. It has got both endocrine and exocrine functions. Anyway, now, what happens when we go to classification in general? When you look at classification in general, we are saying that type 1, as it was called, was where there is absolute lack of insulin. You don't just have the insulin. So what was the properties or characteristics of type 1? One, we knew that it was juvenile onset. It would happen more in children because they are born with this condition. Number 2, you find that these ones have absolute lack of endogenous insulin, so they will just need insulin for survival. These are kids who have seen, who have grown up injecting themselves. They are used. They are not even scared of a prick because they've lived like that for years. And also don't forget, they understand their condition better than you. You can be an endocrinologist. Then you just wake up, make your own calculations and say, no, let's change the dosage of insulin. Morning we'll be giving you Acrafen 20, evening 15. If the child says, no, I think that's too much, doctor, put it at 18. You start negotiating. But 18 is a bit too low. Okay, let's negotiate. What about 19? No, 19 is too high for me. Because that child understands the condition better. They've lived with it. So they will even guide you. The same applies to other conditions as well, where people have lived. Sickle cell. They know their condition. They even know what can cause a crisis. An asthmatic knows what can lead to an asthmatic attack. So for me, I always prefer listening to them first. Even for children, if the mother is there, they are scared, the mother will be upset with them. They will wait until the mother goes. Then they will tell you, Uncle, I was playing in one. That's what has caused this crisis. Not if you might answer. No, what part of physiology? What? They will be laughing at you because they know. So you need to do that. Type 1. But other than juvenile onset and needing insulin because they lack insulin, what else do we see? We see a lot of weight loss in them. And because of this pathway, they are prone to diabetic ketoacidosis. And then also you find that these ones, the familial association is not so much. Much as they are born with it, but it doesn't really run as much in families as the type 2. And basically those are some of the things we used to call type 1. Type 2 means that the insulin is there, but initially what was thought was that it's being masked maybe by fat. Imagine you've got a magnet and you put a plastic on top. Sugar is this side, but it can't see the magnet. It can't see the gate. No wonder people thought, no, just exercises, no, just this, no, that. But now we see later on that actually it's to do with the loss of sensitivity. It's like you have the magnet, it's in the sugar, but it can't just pick it. Or it could be that there is the autoimmune destruction of this, what's called antigenic mimicry. There is implication with cow's milk and all those things. But one of the things you need to know is that these isolates will just be destroyed one by one by autoimmune processes. No wonder you might find that it will be linked with other autoimmune diseases. And if you analyze it further, yes, most of them will have weight gain, and most of them will not have decay, but will have what? HHS, which is? I don't know. Hyperosmolar hyperglycemic state. Or is it hyperglycemic hyperosmolar state? Yeah, I don't know. But previously it was called HOMC. Hyperosmolar non-ketotic coma. Something like that. But now the name has changed to HHS, which is hyperosmolar hyperglycemic, or hyperglycemic hyperosmolar state. I don't know, HHS. And then also, very high familial predisposition associated with what's called HLA-D, 3, 4, human leukocyte antigens, and all those issues. Now, what is the point? The point is that people are now moving away from this classification because a type 2 diabetic will eventually need insulin. I don't know from your experience whether you've seen that. The patient has been on glibenclamide, also called Dawanil, and metformin for many years. Then later on, these drugs just become ineffective. They start losing weight, they start having complications. I mean, you've lost all the isolates by autoimmune destruction. You have no choice but just to put them back on insulin. Meaning that insulin dependent and non-insulin dependent diabetic mellitus classification is losing its favor. Okay. Now, away from that, let's look at diabetes mellitus in pregnancy. So, because I've talked about the drugs, and I will not talk about these drugs because we don't use them in pregnancy, metformin, which is a biguanide, its job is just to increase the sensitivity of insulin. No wonder we like it a lot as midwives in treating polycystic ovarian syndrome. Because the problem with polycystic ovarian syndrome is more to do with insulin insensitivity as part of the treatment panel for polycystic ovarian syndrome. At the same time, you find that Dawanil, which is glibenclamide, which is the sulfonylurea, its job is to produce more insulin. So Dawanil is producing more insulin. Metformin is increasing the sensitivity. So it depends on what you want. If you be producing more insulin, what will happen? You will start gaining more weight because insulin is an anabolic hormone. You see? At the same time, it will cause a lot of hypoglycemia because you're just producing too much insulin. But metformin works by a different pathway. So just sort of highlighting the differences in these two common medications. Finally, again on this diagram, why is it that we say diabetes everything brown? We like brown bread, brown rice, brown shima. Again, don't over-restrict your patients. Meaning that if your patients don't have breakfast meal, you tell them, no, don't eat anything. Because you end up restricting them with everything. So why can't you just allow them to eat whatever they want? So what is the principle behind the browns? There is what is called the glycemic index. If you eat brown rice, by the time it's reaching the part where absorption occurs, maybe only 70% of that carbohydrate would have been broken down into glucose. The other 30% will enter into the parts of the intestines where absorption is not possible. So you will lose part of the glucose by taking things which are high in terms of fiber or in terms of the way they are made, compared to taking very refined foods. Because if you take very refined foods, yes, they are not sugar on themselves, but by the time they reach 100% of them will become glucose. So much glucose will enter, meaning this vicious cycle will become even worse. But we all know that the problem is not even with the sugar, because other people are scared. Yeah, because I took some sugar, I feel very bad. I took 2 teaspoons of sugar. Normally, don't take any sugar. You have to tell them, no, don't feel bad, because it's not the sugar which is the problem. The problem is with the insulin. Okay, so I've mentioned this because you find some people are being enslaved, even by ourselves. And they lead very miserable lives. There is a party, them they are just watching, I'm diabetic. There is a cake, I can't eat. They bring a fruit like pure fruit juice, I can't eat. Me, I only take sweeteners and water. Now, can you live your life like that? Yes, so even when the nutritionist or whoever is giving advice is giving, try to attach science to what is happening. If you are not convinced, then allow them to eat whatever they want so that they live a normal life. Okay, so having said that, we go to classification in pregnancy. Now, in pregnancy, there is no special classification, really. But at postgraduate level, there are many more classifications of diabetes. We come across chemical diabetes mellitus, this, that, but that's not important. Let's just call it as pre-existing, which can end up, okay, or gestational diabetes mellitus. So it can either be pre-existing, meaning it was there, or it's gestational. Though gestational can later become what is called overt, which now makes the patient go into pre-existing again next time. In other words, it becomes a real diabetes. And usually when gestational becomes overt, it becomes of a type 2 behavior. Okay, we are moving. What is the gestational diabetes mellitus, GDM? So gestational diabetes mellitus is defined as glucose intolerance of variable severity with the onset or first recognition in pregnancy. Glucose intolerance of variable severity with onset or first recognition in pregnancy. Similar definition to peripartum diabetes, peripartum dilated cardiomyopathy, if you are to define it. Now, why do we call it gestation? We call it gestational because it only comes in pregnancy. Very similar to preeclampsia or PIH or forms of gestational hypertension, but except diabetes mellitus becomes an issue after 24 weeks. Remember, preeclampsia is 20 weeks? Diabetes is a bit later. Let's give it a range, 24 weeks, maybe to 28 weeks, but mostly around 24 weeks. That's when you start looking out for gestational diabetes mellitus. What is glucose intolerance? Remember, we had the range. If we are saying fasting is 7.8 and the random is 11.1, it means we are allowing for sugar to float around between 7.8 and 11.1 when you eat. But that floating around should not persist beyond 2 hours. meaning after 2 hours of eating, it should revert back to normal values. Well, still, if you are going above, now let's assume you've taken 75 grams of glucose. It's called the glucose load. After you have starved the person for some time, you can go and read on how the glucose tolerance test is done. Then you start checking. You give somebody 75 grams, meaning it's the only glucose in the body because they had starved. Then you check after 2 hours. Then you check what are the numbers. Are they fitting into that or are they above? So depending on your authority, you can use 75 grams, others use 100 grams, others use 50 grams. Others check for 2 hours, others check after 1 hour. I don't want to enter into the complexities of that, but some of us have adopted WHO with respect to all glucose tolerance. Yes. Meaning that sometimes you'll find that the values are not so high to cross the 11.1 threshold for diabetes mellitus diagnosis. But they're just floating within that range, but persisting in that range. So we can call that glucose intolerance. It's like, yes, glucose is rising, but it's overstaying in that range. It's clear? Yes. So it's a milder form of diabetes mellitus. No wonder GDM is defined in terms of glucose intolerance as opposed to diabetes itself. Yes, but you can read more around that. Okay, having said that, effects of pregnancy on diabetes mellitus. I can see. Okay, so let's look at the effects of pregnancy on diabetes mellitus. Now, one of the things we need to know is that diabetes mellitus is encouraged or enhanced when one gets pregnant. So when one gets pregnant, diabetes celebrates. Let me put it that way. It enjoys. It even goes further up. Why? Why is that the case? So we know that pregnancy is diabetogenic. It likes encouraging diabetes. The reasons are simple. It's because when one is pregnant, there is formation of the placenta. And that placenta produces several hormones. Now, one of the hormones that the placenta produces is known as the human placental lactogen, HPL. I've written notes for you, don't worry. And the newer name for human placental lactogen is human chorionic somatomamotropin. Human chorionic somatomamotropin, HCS. So what it does is that it increases the glucose in the mother. Imagine that sugar there is increased in the mother, deliberate, postprandial, meaning after eating. The sugar is kept in the mother's system, so that that sugar, once it's a lot in the mother, it can cross the placenta by facilitated diffusion to go to the baby. So it's like you are sacrificing the mother for the baby's enjoyment. So that is how HCS or human placental lactogen works. So obviously, in that phase, when it increases the postprandial sugar, the sugar will rise in the mother. So that is the reason number one. But it's not only human placental lactogen or human chorionic somatomamotropin. We also have other hormones, like what are called the stress hormones. Cortisol is one of them, catecholamines, and also don't forget the estrogen and progesterone. All these will be working together to try to make the diabetes become high. Number two, the other effect of pregnancy on diabetes mellitus is to do with the emergencies. Now, the emergencies, again, I go back on this one. There are two types of emergencies. There is acute and the vascular. And under vascular, we have micro and macro. So I should have said acute vascular. Then under vascular, yes, Maybe let me put it that way because I don't want it to seem as if there are so many. So there is acute and the vascular. Under vascular we have micro, vascular and macro vascular. Under acute we have DKA, HHS and the hypoglycemia. So these are like the general classification of diabetic complications. Now what are we saying? We are saying that when one is pregnant, those, both the acute and the vascular complications become enhanced. Meaning if they were not there or they were not present in this diabetic lady, it will even appear. How? Why? It's because when one is pregnant, they tend to have hyperemesis. So they will vomit more, and that will lead to dehydration, and you know that is one of the precipitants to diabetic ketoacidosis. That's one. Number two, don't forget that they'll continue taking oral hypoglycemics or indeed the insulin, but they will be taking less because they feel like, I don't feel like eating today. So if that is the case, then you find that they will be at risk of hypoglycemia, right? Vascular complications are also common when one gets pregnant, especially the micro, not macro, but micro, particularly diabetic retinopathy and the nephropathy and other such problems will be more common when one is pregnant. So in other words, pregnancy brings diabetic complications closer. It's clear? Yes, and then the other one we've already mentioned is that the control of sugar becomes more difficult when one is pregnant. Okay, what about the effects of diabetes on pregnancy? What does the condition do to pregnancy? And you say these are the complications we need to talk about. Let's go to fetal antepartum. Now, one of the problems, and in fact this is a very important subtitle for you to remember, the management, because management will talk about this. Management will talk about this. And to some extent this. Why am I saying to some extent this? Is because of this diabetogenic behavior of pregnancy on diabetes, you find that oral hypoglycemics will not work. We had a real client, I don't know if you remember that one, where she was on oral hypoglycemics, but when she became pregnant, she just couldn't control the sugar anymore. And we had to put her on insulin. Because insulin is more potent than any of these oral hypoglycemics put together. Because these are just lowering the sugar. The insulin is actually sitting on the cells and drawing the sugar into the cells. So if you compare the two effects, definitely they are not the same. So let's start with fetal. Now, antepartum. One of the problems we have is congenital fetal malformations. These fetus will not be formed properly. And what are those systems that will be affected? Almost any system of the fetal body will be affected. Let's start with CNS. CNS, they'll be at risk of anencephaly, basically neural tube defects, open neural tube defects. So the anencephaly, you'll be at risk of spina bifida, you'll be at risk of holosencephaly, and so on and so forth. So it's a bad condition. Away from the CNS, we go to the cardiovascular system. Almost any congenital heart disease we talked about, from Epstein anomaly, I know we never talked about, Mulenga, total anomalous hypertrophic pulmonary venous return, truncus arteriosus, transposition of the great vessels, TOF, and including even the cyanotic ones. But what I've observed is more common is ASDs. Alpha-septal defects are quite common from my little experience in diabetic mothers. Whenever the baby is born, it's always good that they do a cardiac wake-up on the baby. Let's go from CVS, we go to the respiratory system. Respiratory, top on the list is the, almost called it hyaline membrane disease, but we never call it that. It's the respiratory distress syndrome. You've heard of respiratory distress syndrome. I know that was the only reason why we give steroids. Yes, well, that is one of the problems. The other problem is the pulmonary hypoplasia. Very dangerous. It's like the lungs have not formed. Not compatible with life, actually. Now, the last one is delayed fetal lung maturity. So there are a lot of issues with the baby's lungs in a diabetic. No wonder you cannot use the weight or the size of the baby as a marker for management. You understand? You use other parameters. Okay. So the other system at fault is the GIT. So they will be prone to sliding hernias, diaphragmatic hernias, these tracheoesophageal fistulas, esophageal atresia, duodenoatresia, mention them, including situs inversus, totalis, and other many problems of the GI. We go to the renal. Polycystic kidneys, they'll be at risk of duplex ureter or double ureter. They'll be at risk of a lot more problems in the kidney. If you go to the musculoskeletal, they're at risk of what's called caudal regression syndrome, which is also not compatible with life. It's like the lower part of the vertebra is not made. And some people would call it sacral agenesis or caudal regression syndrome. So which system? All the systems are affected. CVS, but top on the list is the cardiovascular and the CNS. But you have all this list of problems that can affect any system. Now, away from congenital fetal malformations, what are the other problems? The other problems are intrauterine and growth restriction. I know people always think of diabetes babies as being big, but you can have very small babies as well. So that is known as the intrauterine and growth restriction. Then the other problem which can be there is that the baby can develop fetal distress, and when we get into intrapartum, because usually the babies are big. Why are the babies big? Macrosomia. It's because, remember, we said the sugar which is in the mother is crossing by facilitated diffusion to the baby. The baby is receiving a lot of sugar. So what does the baby do? It has no issues with its insulin. So it will create hypertrophy or overactivity in its pancreas to produce more insulin to counter the high sugar from the mother. Now, in producing more insulin, what is it doing? It's creating an anabolic or building block type of hormone, which will lead to fat deposition. And once there's a lot of fat deposition, the baby will bulge and become very big, 5 kg, 6 kg, and that way. So that is one of the problems we have for the baby. So IUGR, macrosomia, fetal distress, congenital fetal malformations. These are the 4 main problems that the baby will, or you need to look out for in a baby that has got the mother with diabetes. Intrapartum, what are the problems? Obviously, a big baby will need prolonged labor. Right? So there's basically a risk of cephalopelvic disproportion. Then the other problem which will be there, obviously, is that when the baby is born, remember you had a lot of sugar in the baby. and a lot of insulin. When the baby is born, you cut the umbilical cord, you've stopped the sugar flow, but the baby remains with its pancreas and insulin. So what will happen? The insulin in the baby will now go and sit on the cells and throw all the sugar inside the cells. The baby will go into what? Into hypoglycemia. So that's why hypoglycemia is very common. I've seen some babies who can have sugars of 0.5, 2 millimoles, and it takes long for that sugar to peak. So that is one of the problems. What are the other problems? The other problems are to do with the electrolyte imbalance. So there will be issues to do with magnesium, issues to do with potassium. Again, for you to understand this, you need to understand insulin secretion. What exactly happens? And that will be in physiology. Then, other electrolyte imbalance and hypoglycemia, they are prone to polycythemia. How does polycythemia come about? It's about understanding the oxygen dissociation curves. If you remember the factors which makes it shift to the left and to the right. Dr. Mia, do you remember the Howden effects? A bit. There was what was called the Howden effect. I remember those. If you really want to understand hemoglobin and how carbon dioxide and the oxygen behave in these cells, in the red blood cells. I think one day we just need to, but it's more pushing us towards a postgraduate lecture, but it will be like to do with basic science, for us to understand exactly what happens with respiration. Because you breathe in air, but somehow the oxygen goes inside the cells. It goes in the cells, but it's transported by red blood cells. Either as oxyhemoglobin, or some of it will just find its own way using other pathways. So I don't want to delve into that. But I just wanted to talk about how polycythemia comes about. Next, what happens to this baby? They are prone to neonatal jaundice. Neonatal jaundice. And finally, you find that these babies are prone to respiratory distress syndrome, because we just talked about it. That's all. Yes, so no wonder, even if the baby looks stable, take them to NIC. It's not because it's just sugar you're interested in. You need an ABG, so to check the electrolyte profile. You need to check for the hemoglobin, so that you know what polycythemia. You need to check for this and that, because the baby is prone to many more other problems other than hypoglycemia. Clear? Then one of the things I didn't talk about in the antepartum, excuse me for that, is yes, we talked about congenital fetal malformations, which will affect all the systems. We talked about IUGR, which can be symmetric, especially if the problem started as pre-existing. We talked about fetal distress. We talked about macrosomia. 4. But the 5th one, which I put it on standby because I like talking about it in combination with other conditions. Sudden IUFT. Not passing through the line of fetal distress. But the baby was okay, then baby just stops. I've always argued to say there are other conditions which are like that. Hypertension, post-deaths, sickle cell, and diabetes. You are always walking on eggshells when you have a patient with this, because they will surprise you that the baby was okay, next fetal heart can't be picked. When the midwives who are coming to get the afternoon shifts want to confirm the fetal heart, they can't feel it. That prompts them to ask for a sonographer to come put a probe there on the abdomen, and there is no cardiac activity. It can be so devastating and traumatizing to the patient. So that is how you need to always think of diabetes, to say you are always on a risk especially if you haven't controlled the sugar well. Okay, so we will continue tomorrow on maternal. Oh, I just finished. We've already talked about the acute ones, the DKA, HHS, and hypoglycemia. Then for the vascular complications, we have the microvascular. Remember, there are 3 pathies under microvascular. Which are those pathies? We have retinopathy. Do we still remember the stages of diabetic retinopathy? We have background, we have pre-proliferative, and then we have those now parts which now damages the retina completely. You can go and don't confuse it with hypertensive retinopathy. But I remember something like cotton wool, silver wire, AV nipping. But then on this side you have the dot and blot hemorrhages and things like that. Yeah, but let's all go and revise. But retinopathy is one. The second one is what? Nephropathy. And then the other one? Neuropathy. Because it's affecting small nerves, not so. Like remember the vasa navorum. And these small things, all those will be affected. So you have this picture for microvascular. It's the 3 pathies: retinopathy, neuropathy, nephropathy. But if you look at macrovascular now, you're looking at bigger vessels. That's how maybe atherosclerosis will come in. That's how issues of diabetic foot will come in. Have you ever heard of a condition known as necrobiosis lipoidica? We can look at myocardial infarction. You can look at other conditions up to severe. So those are macrovascular issues. So these are the general or medical, if we were to call it medical. Maybe we would have defined it as medical and the obstetric. Because now under obstetric we'll go into antepartum, intrapartum, and postpartum. So what are the antepartum complications? The first thing that we know is miscarriages. They're at risk of miscarriages. Number 2, they're at risk of infections. Remember? So they're at risk of UTI, pyelonephritis, they're at risk of candidiasis, and any other infection of the lower genital tract or indeed upper genital tract. What else? They're at risk of pre-eclampsia. Remember, pre-eclampsia diabetes featured. Then they're at risk of polyhydramnios. Why are they at risk of polyhydramnios? Because you are giving the baby so much sugar. The same process is happening in the mother passing too much urine is what the baby is also doing. Mother is saying, may I give the urine? I'm going to pass urine. Even the baby passes. Now, if the baby is passing more urine, what is happening? The liquor volume will increase because most of the liquor is basically fetal urine. You see, so polyhydramnios becomes an issue. Then, if you analyze further, for intrapartum now on the side of the mother, you find that they are at risk of prolonged labor for the same reason that we talked about, right? The babies are big, this and that. What else? Postpartum. Because I don't know that to put it under intrapartum or postpartum. They're at risk of shoulder distortion. Why are they at risk of shoulder distortion? It's because the deposition of fat, we are just saying the baby bulges. But even if the baby is not big, let's say the baby is 2.8 or 3 kg, the deposition of fat as a result of hyperinsulinemia will be more in the shoulders than in the head and neck. So the baby of a diabetic mother can easily get stuck, and you end up with the shoulder distortion. Postpartum, you find that the milk production of the mother will be affected. It will be low. The other problem which will be there is that the
risk of pupillary sepsis.
And of course, in future, you'll find that this mother can end up with overt diabetes mellitus, because now it will just be diabetes permanent for her. So basically, those are some of the effects of diabetes mellitus on pregnancy. So tomorrow, we finish the last bit of it when we look at management of diabetes mellitus in pregnancy, from preconception going all the way through antepartum, intrapartum, and postpartum. I beg to end at this point, but most of these will become more clear when you look at management. And as we share the notes, it will be very easy for you to follow, because everything I've said, I think I included, except just for that general diagram, which is simple, but I think it's a good reminder. But it's up to you. The more details you read, the more you add more science to this diagram. But use that as a general template, both to explain to your client and to remind yourself. Okay, can end there.